Hi, everyone. My name is Hao-Hua Wu. I'm an orthopedic spine surgeon at UC Irvine, and I am the director of the Global Spine Research Initiative here. And I'm very excited to be giving this talk today on spinal epidural abscess with a particular focus on when surgery is appropriate. I do not have any disclosures, and I'm going to start with a case. This is a patient that I took care of last year. She was a 72-year-old female, Spanish speaking, end stage renal disease on dialysis, diabetic. She was admitted to medicine for coagulase negative staph bacteremia, complaining of several months of upper back pain. And these are the labs below, the CRP of 15 and a white count of 9.3 without an ESR. And she had a CT scan when she initially came and was admitted to medicine, where the read was that she had vertebral body fractures that were thought to be compression fractures and also thought to be chronic. So unfortunately, spine surgery was not formally consulted at that time. But as we will find out later in this presentation, I want you to think about this patient's case as we talk about spinal epidural abscesses and the risk factors that might lead to a patient failing non-operative treatment and needing surgery. And the learning objectives that we have for this talk is that first we're going to define what a spinal epidural abscess is, how that's different from osteomyelitis, discitis, and paraspinal abscess. We'll talk about imaging pearls and focus on risk factors for non-operative treatment failure. And if you do need to do surgery, what are the indications and options? So spinal epidural abscess, it's important to understand the anatomy for the spine to know what we're focusing on here. So it means it's an abscess in the epidural space, which is the space that surrounds the dura, or where either the spinal cord or the nerve roots run. So it's basically what you see in green here in the sagittal and the axial. And it could come from other parts of the spine, like in this case, what's highlighted here is showing you what vertebral osteomyelitis is. That's spelled incorrectly, but that should say vertebral osteomyelitis, which means that that's infection that's within the bone. You can also have infection that's within the disc. But what's interesting about infection within the bone and the disc, if it does not seep out, if the infection does not go out to the epidural space, then it doesn't have the risk for neurologic compromise. So when it does seep out into the epidural space, which is a spinal epidural abscess, it can lead to things like paralysis if you're at the cord level, or nerve root deficits if you're down in the lumbar spine. And it's the compression of the neurologic elements that a lot of times make the patient symptomatic and require the need for surgical intervention if certain risk factors are present. So this is just a graphical representation or figure representation of where the abscesses might be within the epidural space, either ventral or dorsal. So that's learning objective number one. Learning objective number two, there's a lot to think about with imaging, but if I could impart one take-home point for you all today is when is it appropriate to get an MRI? And more importantly, what kind of MRI do you get? So what I would actually advocate for and argue is that any patient that you're concerned about for a spinal epidural abscess, that you try to get an MRI of the entire spine. MRI of the C, T, and the L spine to make sure that there are no non-contiguous lesions. Because of the vascularity and the unique vascular anatomy of the spine, specifically with the Batson venous plexus, if you see infection in one part of the spine, like such as the lumbar spine, that infection could also carry its way up to other parts of the spine, such as the thoracic spine. And what you see here in this paper from the Spine Journal from Bono and Harris is risk factors for requiring MRI of the entire spine to rule out non-contiguous lesions. And those include an ESR greater than 95, an infection outside of the spine, such as a paraspinal abscess. So paraspinal abscess is an abscess that's outside of the spinal canal and the soft tissues. That could be, for instance, a psoas abscess. Also, patients who are delayed 7 days in their presentation have this potential risk factor for non-contiguous lesions. And you also may have fractures in the setting of infection, which makes it even a higher likelihood of non-contiguous occurrence. In terms of what you can do when you identify the spinal epidural abscess, let's say you're able to obtain the MRI scan and see what's going on, you can treat this either non-operatively or with surgery. And actually, the interesting part of the spinal epidural abscess topic is that a lot of patients with these lesions can be treated very, very well with non-operative treatment with appropriately targeted IV antibiotics. And the reason why that is unique to the spine is because the spine is particularly vascular, whereas if you have infection in other parts of the extremities, you may not be able to allow the antibiotics to reach those areas of infection. So for patients that you suspect to have a spinal epidural abscess, as long as they don't meet the risk factors for surgery, which we will get to later, my recommendation would be that you try to do a biopsy first before starting any antibiotics. This biopsy can be performed either closed or open. And later on, in terms of future directions, we'll talk a little bit about potentially doing an endoscopic biopsy. And then once the biopsy is obtained, then you can start broad spectrum IV antibiotics. And as the culture comes back from your initial biopsy, you can then start to work with the infectious disease team in your hospital to narrow the antibiotics for the appropriate coverage. If patients fail non-operative treatment, and this is what we're going to focus our lecture on, surgery then is indicated, and what exactly are the indications for surgery. And surgery options include decompression and biopsy, stabilization, or both decompression and stabilization for patients who need it. In terms of surgical indications, this is another learning objective for this talk. Things to remember are patients that have risk factors for treatment failure, and we're going to get to that in the next slides. Look for failure for medical management, typically defined as over 1 week of appropriate IV antibiotic treatment. Patients that have instability, like if you have an unstable fracture in the setting of infection, those patients need to be stabilized. If patients have progressive neurologic deficits, that's another indication for requiring surgery. And then you may also indicate a patient for surgery using one of the many scoring systems that are out there that predict non-operative treatment failure. And then we're actually going to go over some of the scoring systems, including the 2 scoring systems that I think are the most relevant and the most interesting. So first, this is one of our learning objectives as well. We have to understand the risk factors for non-operative treatment failure. And if you're in the US, these are the 2 papers that are most frequently cited on your board, your orthopedic surgery board exams. Both papers are published in 2014, one from Harvard with Chris Bono and Mitch Harris. And they found patients who were over the age of 65, diabetic, had MRSA or methicillin-resistant Staph aureus and neurologic deficits, were more likely to have failure of non-operative management, particularly patients who had 3 or 4 of these 4 factors. Chapman and Bella Barbara from University of Washington, also in 2014, published a similar study, and they found patients that had a white count greater than 12.5, CRP greater than 115, positive blood cultures, and diabetes. These were patients that were also at risk. And I highlighted diabetes because this is the only one that was the same between the 2 papers. So you got to remember one non-operative treatment failure risk factor, it would be diabetes for your patient. But they also found something similar where if you had patients that had 3 or more of these risk factors, they were at risk for needing a surgery. Now I'm going to introduce you some new scoring systems that have been developed since the publication in 2014. And you'll see a table in the next few slides of all the relevant scoring systems, but I'm only going to highlight two that I think are particularly practical and also particularly interesting. So the first one is the SITE score, the SITE score, which stands for Spinal Infection Treatment Evaluation Score. This was a paper published from Jens Chapman's group in 2022 that tried to develop a scoring system that was predictive for treatment for de novo spinal infections. And they modeled this similar to the SIN score for pathologic spine tumor fractures and predicting stability there. So if you're familiar with the SIN score, you will look at this score and see some similarities. So the SITE score, the SITE score, I think is interesting for trainees or those of you who are new to this topic to look at, because it does outline 5 interesting factors to consider when looking at treatment options for patients. It looks at neurology, location of the spinal epidural abscess, radiology, the radiological findings, pain, whether or not there's mechanical back pain or not, or mechanical neck pain, and host comorbidity. Specifically, they just highlighted IV drug use and diabetes as the only 2 comorbidities that would be more risky for needing surgery. The only thing that I think is you have to watch out for the score is that the scoring system is not as intuitive as a SIN score. With a SIN score, the higher the number, the greater the instability and the greater the risk of failing non-operative treatment or the greater need for surgical treatment. In this case, in the SITE score, it's actually the lower the score, a score that's 8 and below, that is indicated for surgery. And patients who have a score of 9 to 12 are in that intermediate group where surgery is optional. And patients with a 13 to 15 are patients that can be treated well without surgery itself. And for neurology, things I want you guys to be aware of if you're a trainee, if your patient has acute paraplegia or acute weakness and bowel and bladder dysfunction, that's automatically surgery. You don't even calculate the score, you take them right to surgery. But then these other things to consider for location, for instance, if you're in a junctional area for the abscess or the infection, that is more likely to require surgery because the score here is lower. If you have spinal canal stenosis with or without deformity, you're a high likelihood of requiring surgery. If you have mechanical pain, and if you have IV drug use or diabetes, those are the things that are valued in the score as risk factors for treatment failure. The other scoring system I want to highlight to you is a scoring system that came out in New Zealand in 2025 in the Global Spine Journal. And it aimed to actually develop a score that eliminated confounding bias with the use of a pre-factorization correlation matrix. So the thesis of this paper was that the other scoring systems that are out there for predicting the need for surgical treatment in spinal epidural abscess, the factors and the demographic risk factors that they use to run logistic analysis did not account enough for confounding. So this was their way of trying to eliminate confounding bias. And what they found was they developed a score that's called the CSF score. They just spelled it wrong here at this table, but everywhere else is spelled as CSF. And that stands for comorbidities, severity, and function. So if you have any of these comorbidities, you get 1 point. If you have any of these clinical severity factors, you get 1 point. And then if there's functional status is not independent for the patient, you get 1 point as well. So that's a CSF score. And the more points you get, the higher the risk of failing non-operative treatment and higher risk of mortality. If you are actually familiar with the New England Spinal Metastasis score, the NESMS score, this is very reminiscent of that score as well. There's also the CS3F score, where they also add additional points for biological severity if you have one of these laboratory markers, and also for radiologic severity if there's disc or bone involvement, you get points as well. With the more points being more likely to need surgery. And what I like most about this paper is that, while the scoring system itself, I think, is interesting and novel and, did try to account for a confounding bias, trying to eliminate collinearities between the risk factors. It also shows how the score, the CSF score here, it's spelled correctly on the table, compares with the other scores that are out there, such as the SITE score that we just covered, or the SWORD AI score that was developed by Joe Schwab and colleagues out of Harvard, and other scores such as the Modified Frailty Index. So this is a table that you can peruse at your own leisure. If you're trying to choose a scoring system to use, I think it's important to know at the very least what the strengths and weaknesses of those scores are. So now I'm going to go back to our case presentation now that we're armed with the knowledge of what to look for potential failure, for treatment options, for non-operative treatment for spinal epidural abscess. If we look at this patient who's 72, is diabetic, is bacteremic, and has these lab values, we may look at this picture in a different light. And for those of you who are also taking a look at this CT, I want you to just take a look at the amount of deformity in the fracture itself. That looks like a pathologic fracture rather than just a normal compression fracture. And it's the kyphotic deformity at the level of the spinal cord and thoracic spine that can be very risky for patients in terms of their spinal cord function. So this patient actually, after 4 days after admission, started developing lower extremity weakness, numbness, urinary and bowel incontinence, became an ASIA A. And these are the risk factors she had for non-operative treatment failure for a spinal epidural abscess. She's over the age of 65. She's diabetic. Now you learn that she's developed neurologic deficits, and she's also got positive blood cultures for staph, coagulase negative Staph aureus. And if you're using the SITE score, which, if you don't want to use the non-operative treatment failure risk factors that were from the 2014 papers, I think the other one that's most structured to use would be the SITE. The SITE score for a patient that has bladder and bowel dysfunction or acute plegia, you're already taking them to surgery. You don't have to count out the numbers. And this is an MRI that was obtained after the CT that occurred at the time when patients started losing function. I highlighted here cross-section up at around T3-4, where the spinal cord looks normal in the axial view. Here in the T2 weighted image, you'll see the spinal cord here kind of looks like an egg yolk, and it's surrounded by egg white. And the egg white is the space that's essential for that spinal cord to be healthy. So if you see egg white around the egg yolk, that's a good thing. And then here at around the level of T5, where the spinal epidural abscess starts, you'll see that there's both a pathologic fracture component and also an epidural abscess component from what appears to be a fracture. So it looks like it's pathologic. The fracture occurred because there was osteomyelitis or infection within the bone. And if you look here, you can't see the spinal cord very well. The egg yolk shape is unrecognizable, and the egg white seems to have disappeared. So in this patient who has an acute thoracic spinal cord injury from a spinal epidural abscess in the setting of a pathologic fracture and multiple levels of stenosis, because as you see here, it's not just stenotic here at T5-6 where the worst fracture is, it was also stenotic down to T8. We chose to do a T2 to 10 posterior spinal instrumented fusion with a laminectomy from 3 to 8 and a left-sided T6 transpedicular decompression just to push away the fractured bone from the front to give the ventral cord space. We also sent off the bone for additional culture. And because of how weak the bone was, we chose to do cement augmentation for the screws above and below the construct to help augment the stability. So after surgery, the patient improved from an ASIA A to an ASIA C. And the last thing I want to impart you with for future surgical options is that as more advances in our spine capabilities, spine surgical capabilities grow, endoscopic surgery may be an option for patients who need not just a biopsy, but an IMD. So in our setting here at UCI, the standard of care is that we need a biopsy. We ask IR or a radiology group to get a needle biopsy of the site. But more and more, we've been doing endoscopic biopsies and irrigation debridement, because endoscopic surgery, you have a lot of irrigation fluid that can run through that site, which is an effective treatment for the fracture itself. And we did a study here at UCI to compare the yield, the diagnostic yield of CT-guided needle biopsy with percutaneous endoscopic debridement. And it showed that the endoscopic debridement and drainage technique found actually a significantly higher yield for these infectious organisms. So it's something to consider in hospitals that have this capacity. The other thing too to keep an eye out for is that carbon fiber implants may have a role for instrumentation, especially if you're trying to track the effectiveness of the treatment of the IV antibiotics after surgery itself, as the carbon fiber implants are radiolucent and allow you to get a really nice MRI after surgery. So in terms of our learning objectives, just remember it's important to get an MRI of the entire spine, especially for folks that have risk factors for non-contiguous spread. For risk factors for non-operative treatment failure, just think about patients who are greater than the age of 65 who are diabetic, have MRSA, neurologic deficits, CRP greater than 115, a white count greater than 12.5, and positive blood cultures. This is especially relevant for US trainees because you will be tested on this. And finally, the surgical indications and options if there are unstable fractures, neurologic deficits, and failure of medical management. You can consider decompressing and getting an open biopsy with or without stabilization. Thank you so much.